score, and the other is the radiology, how the otosclerosis has progressed from the radiology. The trouble that we face in such patients is of the ossification which occurs at the round window as well as the basal term. So we find problems with electrode insertion, and also because of the nature of the bone, we have had patients who had facial nerve stimulation when the switch on has been performed. Then we moved on to doing patients who have anomalous cochlea, IP deformities and common cavities. The classification has been given by Professor Levent Senetoglu. And one major issue that we face intraoperatively is that of the CSF gusher. There are not many ways to tackle it. You can, over the electrode, you can put temporaris fascia graft and plug it, or also foam electrodes have been introduced by Metal, who have a conical opening and they just plug in the CSF gusher. So after starting to implant people with anomalous cochlea, we've now moved on to disabilities, whether that is Waardenburg syndrome, congenital rubella, Wolfram syndrome, Jervell-Lange-Nielsen syndrome. So we have implanted patients who have other comorbidities as well. I believe there's another talk on bilateral cochlear implants, so I won't be touching much of this. But all of us know that 1 year is better than both, and 2 years are better than one, and there are benefits of binaural hearing. Those occur because of phenomenon like binaural summation, squelch, head shadow effect. Also, there's improved speech recognition in a noisy environment as well. So the question is now not if bilateral is helpful, it is whether to do a sequential or whether to do a simultaneous implant. I think that will be covered in the next talk. Moving on to electroacoustic stimulation. I touched upon this in the beginning when in 2014 we started doing patients who have some amount of residual hearing that is present. So talking about this is that at the lower frequencies, the hearing is preserved, and at the higher frequencies, the hearing is gone. So what the implant does, it goes around the base, it stimulates the higher frequencies, and there's an acoustic component to care for the lower frequencies at the apex. So the audiological criteria is pretty clear that at about 500 Hertz, the hearing needs to be either normal or up to a maximum limit of 60 decibel. It can be severe to profound at 2, 3 and 4000 Hertz. The word scores need to be between 10 and 60% in the ear to be implanted, whereas the other ear should have a speech discrimination score not better than 80%. There are certain principles that need to be followed in such implants. They were given by Lenhart. So for the hearing preservation at the lower frequencies, you give a oral corticosteroid, and for the higher frequencies at the base, you give a steroidal preparation through the round window. You should avoid to suck the perilymph. A round window approach is preferred to a cochleostomy, and the one thing which is of paramount importance is the slow and delicate insertion of the electrodes. One disadvantage when it comes to hybrid implants is that there needs to be a minimum length of the electrode, and that is 18 mm, because less than that, if you end up destroying the residual hearing, then you'll land up in trouble. So finally, coming on to single-sided deafness, and the approval for which came in 2019. So what we say is that the auditory deprivation should be less than 10 years. Because if it is more than 10 years, it is preferred to do either a BAHA or a cross hearing aid for such patients, and the benefits are of binaural hearing. The only disadvantage is that it takes time for both the ears to get accustomed to each other, and there is a significant amount of auditory rehabilitation and speech therapy that needs to be done for such patients. So just to summarize what this was all about, so we started in 1985 with unilaterally implanting adults which were post-lingually deafened. We moved on to prelingual children above the age of 2 years in 1990. Then we started implanting patients who had anomalous cochlear or labyrinthitis ossificans, and then disabilities and other syndromic children as well. Then we moved on to doing bilateral, sequential, bilateral simultaneous implants. Finally on to electroacoustic stimulation of residual hearing, and then finally now we are at single-sided deafness and asymmetrical hearing loss. With that I conclude my talk. Thank you.